record button, and I will share my PowerPoint with you. Okay, wait a minute. I'm not sure I did that right. Hang on just a second. Let me do that again. Well, no, that's not it. Okay, hit this first. And share. Okay. Can everyone see that?
Yes.
Catherine, I see you. Okay, great. Perfect. Okay. All right. Okay. All righty. So if we look at Maslow's hierarchy of needs, which you've heard of before and learned about before, you all know that you need to take care of the lower level needs before we can get to self-actualization. So, you know, those physiological needs have to be met before we can get to the self-actualization. So Maslow defined self-actualization in a lot of different ways, but that is being fully, someone has reached their full potential. And it's also, he stated also that it's a state of being psychologically healthy. So this is where we'll be if we're psychologically healthy. Now this, your position on moving up, of course, the physiological first, safety and security, love and belonging, esteem, and then self-actualization. If you would have a mental or a medical problem, of course, you're going to drop back down to physiological because that's going to be your priority. So you can fluctuate between these, but ideally, we want everyone to get to the self-actualization and reach their full potential. So when we look at mental health versus mental illness, mental health is defined as being able to adapt to stressors, so adapt to change, and heaven knows we've all experienced a bunch of that in the last year. So able to adapt to change, cope with the stressors, and two other attributes are having fulfilling relationships with others and the ability to be productive, you know, be able to go to school and go to work. So that is mental health. Mental illness, on the other hand, is where someone is not responding, able to adapt to the changes and the stressors in their life. Their thoughts and behaviors, a lot of mental health is defined by our culture, and we'll talk more about that on the next slide. But as far as the cultural norm, the person's thoughts, feelings, and behaviors are not the cultural norm, okay? Also, their mental illness interferes with their social, occupational, and physical functioning, okay? If we look at cultural aspects a little bit closer, the community of the culture are the ones that recognize the behavior as abnormal for their culture, okay? Family, our wonderful family will try to normalize it for a long time, okay? They'll say, you know, it's just Kathy. That's just the way she is, you know? So they try to normalize it and you know, make it, you know, nothing to be concerned about in their minds. But when there gets to be a point where they can no longer say, you know, this is okay, that they say, you know, no, This is not good, and Johnny needs to get some help for this. So if we look at cultures, some cultures are pretty liberal with their acceptance of a little awkward, a little abnormal behavior. And some cultures are really rigid and have very little tolerance for behavior that, goes outside the cultural norm. So when we look at social class, our socioeconomic classes, our lower socioeconomic classes tend to have more symptoms because their families tolerate the behavior much longer, the abnormal behavior that they're just exhibiting. Couldn't think of the word, sorry. And so they tend to put up with abnormal behavior a little bit more, where our higher society groups, families, have a better recognition of their symptoms and seek treatment more quickly. When we look at psychiatric care in the past, which I'm sure you've heard about, you've seen it in some movies, where it was the psychiatric care that was given was cruel and at times inhumane. The treatment methods. Some of the primitive thoughts in the old days were that they didn't have a lot of understanding of mental illness. So they felt like some thought that it was an evil spirit that had entered the body, and that the only way to cure them is to go through an exorcism, or an exorcist would do the exorcism. And this could consist of brutal beatings and starvation and torture and, trying to rid that body of that unwanted demons. They felt like they were evil spirits or demons that they needed to rid the body of. So we've come a long way in our education on mental illness. Others thought that the individual had sinned against someone or God, so they had to go through a ritualistic purification, and punishment or retribution was required to rid them of this sin that they had committed. And then again, the demonology, and some were thought to be witches for their behavior. So some of them were actually burned at the stake, and some of the people that were accused of being witches actually had mental illness. But they were accused of being witches, and as you've heard of, I'm sure, they burned witches at the stake. Also, some other cultural considerations are the highly educated also recognize their symptoms a lot more quickly and seek treatment. What they found with the Jewish culture is they are quicker to seek treatment as opposed to the Catholic and Protestant cultures. Women tend to be quicker to seek assistance. And they found that if the particular group was further away from the mainstream of the culture, that they did not accept behavior that was out of the norm. They were less likely to accept abnormal behavior. So if we look at mental health and mental illness on the continuum, of course, we all have occasional stress. And mild stress is good, right? You've learned that a little bit of stress gets us up in the morning. I've got to get to school. Well, got to get on Zoom for my class. I've got to get to my job if I have a job. So a little bit of stress we need to motivate us, to keep us going. And that's normal. And as long as we adapt to it and we're able to be productive, have good relationships, meaningful relationships, we're good to go. So when we get to more of a moderate or a chronic period of distress with mild to moderate symptoms, you might have a little impairment, little emotional, could be, some emotional problems or concerns. And of course, when we get to marked distress, then we've definitely gotten into the mental illness aspects. Okay. So our responses to stress, of course, you've heard of the fight or flight syndrome that occurs whenever we are faced with stress. This is where we're going to see our heart rate increase, our respirations increase, our blood pressure increase, headache, sweaty palms, maybe dizziness, okay? And those are the normal reactions to stress. We go into the fight or flight. Chronic stress is where the body is aroused, of course, for an extended period of time. And this is where there becomes a problem with a person having diseases of adaptation. They have chronic headaches, they have mental disorders that occur. It can, cause cardiac issues, coronary artery disease, ulcers, stomach ulcers, bowel issues, colitis. And if there's not intervention for this chronic stress that is not relieved, it can actually lead to exhaustion and death. So definitely, chronic stress can be very, very dangerous for people. So also anxiety and grief are two primary responses to stress also. Of course, we talked about the mild is okay. And then we get up to the moderate, severe, and panic where we are going to have issues with our anxiety. And grief, when there's a stressor, we can go through the grieving process, the stages of grief. And those, of course, are denial, anger, bargaining, depression, and acceptance. And your book goes through that. I started to just do a few pages, but I went ahead and had you read the whole chapter. It's not a big chapter, chapter 1. But don't worry too much about the stages of grieving. We're going to get into more depth with that, with our death and dying in 212. But just want to throw that out there that can be a response to stressors. So when we look at mental health, what are the characteristics? What do we see in a person who has good mental health? And this is a great little picture that lists the wonderful characteristics of mental health. So as long as we're, interpreting reality appropriately, that's a good sign. We love and we experience joy, good sign. And we live without undue fear, guilt, or anxiety, like we were talking about. We all get anxious, and we may have periods of fear and guilt, but it's not a continuum. It's not on a continuum. It's not severe, okay? We're able to think clearly. We're able to problem solve, reason, reach insightful conclusions, and be creative. Those are good characteristics of mental health. Relate well with others. And these will make even more sense when we get into the disorders. And so these are definite areas where folks with mental illness struggle. Okay. Ability to work, it becomes a disorder when you can't work, you can't be productive, you cannot function day to day. So you're able to work and be productive, maintain a pretty healthy self-concept. You feel pretty good about yourself and you value yourself, and you're able to play and laugh. And some of these disorders, you know, depression's one example. These folks don't play, don't laugh, you know, they're pretty lethargic, pretty flat affect, and we'll talk more about that. But that's just one example. Some other characteristics or attributes of mental health are everybody needs a good support system. And you know that with nursing school. You've got to have your nursing school buddies. And I know you guys miss each other tremendously, because I know when I was in nursing school, my little buddy was my best friend forever after nursing school. So you got to have a buddy, you got to have a support system. So family, definitely, you know, they need to take up the slack for you guys, definitely, to help keep you mentally healthy to get through school, right? But those are all good attributes to mental health, is having a good support system. And it could, you know, community. You know, it takes a community to raise a child. It takes a community to get you through nursing school and some other stressors in the world. And this could be your church, family, you know, whatever community you belong to. So good support, spirituality, they have found, and, you know, there's not one particular religion that's going to keep you mentally healthy over the others, but having spirituality is helpful, definitely, and a good attributes to good mental health. Of course, environmental influences can have a negative influence. If there's a lot of stressors in your environment, poverty, if you're, you know, worrying about living one paycheck to the next, you can't pay your bills, you're so in debt, can't feed your family, those are definitely hard on our mental health, definitely. Or if you had impaired or inadequate parenting, we'll talk more about child abuse, and that's going to be in 212 also. And, you know, the long lasting scars from that can affect someone's mental health for the rest of their life. So that's a whole nother story, which is a sad story, but very, very truthful. Biological influences, you know, there is a genetic predisposition to, I would want to say all of them, you know. So not necessarily if someone in your family has depression, will you get depression, but you're predisposed to that. So you have to take care of yourself and be aware of that. Personality traits that you're born with can affect your mental health. You know, if you're very shy and introverted, it may hinder you from having close relationships, which can be a negative influence on your mental health. Also hormonal influences, and all us women, I know we got some guys out there, so just ignore that, but we women definitely have our hormonal fluctuations, and, you know, which can make us anxious. So definitely hormonal influences. Health practices, taking care of yourself, exercising definitely helps. And your cultural beliefs and values definitely also. So those are just a few, but those are good slides to look at as far as characteristics of good mental health. Okay, our little video I already showed you. And, you know, I thought it was really good that they pointed out, you know, as a nurse, we're very important to our patients and advocates. We need to help with this problem of stigmatizing if we're in a situation where we can speak up for folks with mental illness. It's a good thing because it can have a very negative effect on the person's medical and psychological well-being of the individual and the family. With the video, I just was so sad for that mother, Jessica's mother. I mean, she listened to this psychiatrist who, told her basically her child was, spoiled, rotten brat, take her home and straighten her up. I mean, that is very sad that the medical community had a psychiatrist act like that. So just because someone's a psychiatrist does not mean that they are definitely or necessarily a good psychiatrist. And I've seen both in the field. That some are better than others and have different tactics or techniques. That, anytime you get a diagnosis or you hear something, just because it's from a professional, you have the right, and you should get that second opinion. That's why I always think families with nurses, every family should have a nurse to bounce things off of, because, we put a lot of faith in our medical community, but, sometimes there's not great advice given by these medical professionals. So definitely, that was sad to see all the years that Jessica had gone through so much just because of that advice that doctor had given the mother. And then she has to live with that guilt. So, stigmatizing is a definite major barrier to healthcare treatment, mental health treatment. So we want to help with that. Stigma, just to define, is where there's negative attitudes, thoughts, beliefs, behaviors, and they influence the individual. So keep individuals from seeking treatment and the general public. No one wants to be labeled as crazy, they say, which, mental illness is in the head. And, it's just like pain, it is what the person says it is. Okay. We can't get into their brains and see what's going on, unfortunately. But we need to listen, be good listeners, and get them the help that they need, and be supportive that what they're feeling and experience is very real. Okay. The fear for so many people because of the stigma is that they're going to be labeled, that they're going to be separated, that they could lose their job if anybody found out that they were struggling with mental illness, that they'll be discriminated against. And we need to, we need to get past that. And, it's just like, any other illness that gets treated, mental illness also needs to be treated. Okay, all right. So one other statement I want to make about stigmatizing is it erodes the individual's and the public's confidence in the fact that mental illness can be treated. Okay. The stigmatizing makes people feel like they can't seek treatment and that there's nothing that can be done to help them. So those are negative effects of stigmatizing. Okay. So when we look at the therapeutic nurse-client relationship, very important in psychiatric nursing. It is the foundation of psychiatric nursing. Psychiatric nurses have to have that therapeutic relationship with their clients. And that is where, of course, both recognize each other as unique and important. Nobody is above the other. Okay, it's a team relationship where we're working together to improve the situation, the mental illness. And you want it to develop into knowing and respecting each other. And we'll talk about more of that. You're not going to become friends, okay? And we'll talk about the reasons why. You have to have a control over the environment. And, and it's a mutual respect. I respect you, but you need to respect me. And that there's going to be behavior that's not going to be tolerated here, and that there will be consequences, is a big role of being a psych nurse. That we're alike but different, and that you're going to share in the solutions to solving the problems. So the goal that will be mutually agreed on is directed towards learning and growth promotion for that individual to bring about some sort of positive change in their life. Okay. So one example is the client will demonstrate more adaptive coping strategies for dealing with such and such. Okay. And coping strategies are what keeps us mentally healthy. So we need to sometimes teach our patients, our clients, how to use coping strategies, that they've never really used good coping strategies to deal with their stressors. In this relationship, you're going to explore the problems, and perhaps it's relating with others, and how they, sometimes we have to teach people that they've never, perhaps had the role model of showing them how to relate with others effectively in a good way. And also healthy ways of meeting emotional needs. That can be a factor in mental illness. And definitely how can they need to be able to experience satisfying relationships, and what is keeping them from being able to have those satisfying interpersonal relationships, and work on that. So all psychiatric units have what's called milieu therapy. Okay, this is our therapeutic community. All right. So everything on the psych unit needs to have a purpose. Okay, a therapeutic purpose. It's just not done randomly. Okay, it's planned out. They have a calendar. They list, the activities. They list when the group therapies are going to be. The patients meet with their treatment team, and the treatment team consists of the doctor, the patient's nurse, the social workers, the nurse practitioners. So they all get in, and we're all working together to get this person back out into society, and to have a satisfying and positive life. So the milieu therapy, everything done on the unit is considered to be therapeutic. Okay. Your role as a mental health nurse is to provide the structure. So we have to make sure things don't get out of control. Okay. And see when things are escalating and intervene. And so the environment needs to be safe, therapeutic, and collaborative. Okay, so we're working with the patients and the families and the other healthcare practitioners. The goal is that the individual is expected to learn adaptive coping interactions and relationship skills. Sometimes they need to learn these. They've not learned them from their family role models, so we have to teach them. And they also can be applied in other aspects of their life. And a lot of this is done in group therapy. They usually have a goal in group therapy for the group. They don't get into individual issues in the group therapy sessions, but and a lot of times it's okay. Let's talk about how we react to situations that cause us to be stressful. So a lot of times it's teaching them adaptive coping mechanisms. We want to encourage them all to participate in their therapy. And a lot of times that is one of the criteria that they have to meet before they can be discharged, is that they have to be a participant in the therapies that are offered on the unit. And we always want to encourage, support autonomy, their individual autonomy. So the goal, again, of the milieu therapy is to manipulate the environment so that all aspects of the unit are considered therapeutic. Everything we do is considered to help with their therapy. Some basic assumptions of milieu therapy are the health of the individual is to be realized, of course, encouraged to grow. And we talked about that every interaction is going to be a therapeutic intervention anytime you're speaking with them. Because individuals have both strengths and limitations, and we need to help them ID their strengths and use those for them in their growth, in their personality, and their ability to function more adaptively and productively. So we want to create an environment that improves communication, of course, and relationship skills. Those are always primary goals of the unit activities and therapies. The patient is expected to take responsibility for their own behavior, of course. And the behavior group norms are established through peer relationships and peer pressure. So a lot of times peer pressure can be a very positive thing, a great motivator for someone to improve because the group, doesn't accept a particular behavior that someone's exhibiting. And, they let them know in a non-confrontational way that that is not acceptable. And that's discussed a lot of times in group therapy. Also, behaviors looked at to see how it affects others. They might not realize that how their behavior affects others. And so that needs to be discussed and to help them come up with more appropriate ways of behaving or verbalizing their needs. The nurse on the psychiatric unit, again, is a very important person on the unit. They're responsible, kind of like the parent, of setting limits and letting them know the repercussions of unacceptable behavior. And so they set the limits and the consequences for, the limits that are exceeded. They go past the limits that are acceptable. So we always want to, as psych nurses, let them know what behavior is acceptable and the consequences for the unacceptable behavior. So it's very clear, this is unacceptable. You can't be screaming at John, and you need to talk with him in a non-shouting manner. And if you're not able to do that, you're going to have to go to your room and cool down a little bit. So there's always consequences for their behavior. And of course, we'll talk more about consequences. Of course, again, with parenting, we've got to be consistent. We've got to be consistent as psych nurses. Very important to be very consistent with this behavior is not acceptable and these are the consequences. And everybody needs to be on the same page. All the nurses and staff need to be on the same page as far as keeping control of a unit. Okay. Okay. All right. Okay. So the conditions or the things that support and promote a therapeutic community are definitely that their physiological needs are met. A person can't look at their psychological needs until their physiological needs are met, right? Maslow's hierarchy of needs. We've got to take care of those first. Physical facilities are very important. the unit. This will be my first semester going to LifeWorks at Novant, and I'm very excited about it because I've not worked on that unit with students before. So I'm excited about that. I've been at the VA, and the VA has not opened up to us yet. So I wanted you guys to get some psych experience. So I volunteered to take you guys to LifeWorks. So we're going to check out that facility. So I can't tell you as much about that facility, but the VA facility is wonderful. It's fairly new. I want to say within the last, time flies, 5 years, but it's very open and it's very conducive to good mental health because there's plenty of space for everyone. There's 2 TV rooms where the patients, if they're not wanting to watch this show, but they want to watch another show, they can go to the other TV room. Then there's actually 2 outside screened areas. When it's warmer, they can go out and get fresh air. And you say screened in areas. Well, it's on the 2nd floor, and the screen is it's steel. So, if you ran up against it, they tested it, you'd bounce off. So it's very safe, but they enjoy getting that fresh air, which is always healthy and good for everyone. And they make decisions on the unit. The group makes decisions about things that they can make decisions on. So these are the community meetings where a lot of these are discussed. And again, very structured programs, scheduled. And I speak about the VA. They've got their calendar up, their daily calendar, and all the patients know, okay, it's 10 o'clock, it's time for group therapy. It's time for nutrition class. It's time for movie time. They have fun activities also. But everything's scheduled. There's, it's very scheduled, kind of rigid, but that's what these folks need. And definitely we always want to, reach out to our community resources for these folks that need it. And then family, if they're involved, have them involved in the discharge planning to help, make sure that the patient's being discharged to a good situation. Okay. So, what is the DSM-5? The DSM-5 is the Diagnostic and Statistical Manual of Mental Disorders, DSM. The 5 comes into play because it's the 5th edition, okay? And this is the Bible for mental health practice, okay? The manual consists of, and we'll go through that. I'll say, well, we'll talk more about the criteria for meeting a certain diagnosis, okay? You have to have so many criteria underneath this DSM criteria list, and we'll talk more about that. But anyway, it helps practitioners diagnose mental disorders. Definitely helps with getting payment for mental health care. And so it helps with diagnosis. It also gives treatment recommendations and helps with the payment. So very important manual that they refer to. Just an example with depression. Depression is a mood affect disorder, and bipolar is a mood affect disorder. And we'll talk about depression first after our ethical issues and legal issues. To be diagnosed with depression, you're going to have to meet these criteria. Sometimes with bipolar, we can have, just to kind of touch on bipolar just a little bit, is we can have the manic, which is the euphoria, hyperactive state, or they can have bipolar disorder with the depressive aspect. Okay. So sometimes people are misdiagnosed with depression when they actually have bipolar. And so this diagnostic manual can help differentiate, is this bipolar depression or is this depressive disorder, major depressive disorder? Okay. All righty. So that finishes up our first set of slides. Let me just see, does anybody has any question? Oh, okay. All right. Talked about the map. Okay. The question is there a specific time we will be going to LifeWorks, and has that not been worked out yet? The clinical schedule just as Thursday and Friday, 6 hours, but has no exact time. Oh, okay, good question. So they're on a 7 to 7 schedule at LifeWorks, so or 6:45 to 6:45. So the plan is to get there about 6:30, and I will meet you in the lobby downstairs, okay, for that. And 6 hours, so we'll leave about 12:30, 12:45, okay? So that's the schedule. Any questions about that? It's a little different at the VA is why there is no exact time, but since we're not going to the VA, I can tell you that.
So LW means LifeWorks?
Yes.
Okay, and H just means Huntersville?
That's my understanding. Yeah.
Okay, thank you so much. Yeah, I figured
it myself. They're looking.
Okay, thank you.
And I noticed that last group doesn't have any LifeWorks or any other units. So, don't take that to heart. It needs some tweaking. Okay. And I know Miss Bowie or Dr. Bowie put out a note below the schedule that it's not near written in stone, but that she would have it ironed out hopefully by Monday. Okay. So before you go to clinical. All right. All righty. Okay. Well, we can take a little break. How about, and then we'll see if we can get through the ethical and legal issues. Okay. Anybody else have any questions? You can send me a chat. I'm going to pause the recording. Just remind me to start it back up. So if you guys want to come back, I've got 5 after, about quarter after. We'll do just a little bit more. I know you've had a long day, so we'll just try to in the ED with little. It's 1 p.m. to 11 p.m. Will that be both Thursday and Friday, or just one day? We have a total of 12 hours for clinical, so I am not sure if there will be I didn't happen to look at the calendar or the schedule to see if it's said. Does anyone know if there's a debriefing? Does it say Thursday and Friday, or is it on the weekend? I would have to look into that. But the best person probably to check with on that would be Dr. Bowie. She's the one who's setting all the clinicals up. She's the course coordinator. Okay? Is that good? Okay.
Yes, thank you.
You're welcome. All right. Any other questions before we get started? Okay. So there actually are 2 sets of the ethical and legal. I added a few slides on another set, so but they're both pretty short. So I'll go ahead and get that started. And we're recording, so we're good to go. Okay, can everybody see that?
Yes.
Great, thank you. All righty. So there are definitely some ethical and legal considerations with psych nursing. as you can imagine from what we've already talked about. So hang on, I'm just getting that set out of my way there. Okay. So at some point in your career, you will be faced with an ethical dilemma. And in psych nursing, it does come up frequently, occasionally, where you have to make an ethical, you have an ethical dilemma, where there's two situations, and this is usually with consequences. We have to weigh which is the, we'll talk about least restrictive consequences. So, but where a situation, you have to make a choice between two, no, one's not really a better one than the other. They both have positives and negatives. And so you're faced with this ethical dilemma. Which one should I choose? Okay. So it causes some conflict in making that decision. So we need help with that. And so we look towards our ethical principles for help with making these ethical dilemma decisions when we're in ethical dilemma. So the ethical principles are guidelines that can help with the decision making. And we use them in healthcare when we're faced with these ethical decisions. So the first one is autonomy. And autonomy defined is the right to determine one's own destiny. Well, we always want to give that to all our patients, right? That they are able to decide for themselves. But when given autonomy, the presumption is that the individual is capable of making independent choices for themselves, okay? So when we look at psych patients, sometimes they are not capable of making choices on their own, okay? Also, if someone's in a coma, they definitely can't make a decision. Children, parents make the decisions for children. And as I said, the seriously mentally ill cannot make informed choices, okay? So they are not given autonomy. Okay. But as healthcare workers and psychiatric nurses, if you are going to be a psychiatric nurse, you've got to ensure that this is always considered, that, we want them to be able to determine their own destinies and make their own decisions as much as possible. But sometimes we have to make them for them. So that's one of the principles we always want to adhere to is ideally we want to allow that person to make their own decisions. Okay. So as healthcare workers, we want to ensure that we respect the individual's autonomy and that we don't let another person's view interfere with their right to choose that. Does that make sense? So respect their autonomy and not disregard it in favor of someone else's view as best for them. So we want to consider, okay, well, the doctor says this is best for them. The patient says, no, this is best for me. Okay, so we have to meet in the middle, and sometimes we have to advocate for our patients on what they feel like is best for them. Okay. Beneficence is, as the term implies, one's duty to benefit. We want to make our decision on what would benefit the patient most. Okay, promote the good of others. All right. We act on the patient's and client's behalf to be beneficent. Okay. And we always want to make sure that our decisions are considered with, okay, is this going to benefit the patient? And of course, back on autonomy, as I kind of hit on, we do respect autonomy, but it can be overridden, of course, when a big one in mental health is, or mental illness is, if they are risk of harming themselves or others, they lose that right, right of autonomy. Okay, we have to intervene because they could hurt themselves or others. Okay. And the problem with beneficence is figuring out the ethical dilemma is, exactly which is better for the patient. So sometimes, like, we're in a group, chatting this out to try to figure out which would be the most beneficial for this patient. Okay. And then who can make that decision? Who should make that decision? Can the patient make that decision for themselves? There's going to be instances in psychiatric nursing and psych and mental illness where, that cannot happen. They're not able to make their best decisions. So we have to make it for them. And is it the family who should make the decision, or someone has to override that decision? So it can get kind of complicated at times. Again, advocacy, is essential in all nursing and definitely in psychiatrics and nursing. And of course, we always want to support or defend our patients as needed. So one of the roles of a psych nurse can be that they have to help that patient get their needs met. That if they didn't have us help them with their needs, they would not get met. And one comes to mind is with our depressed patients. If they are super majorly depressed when they come in, they've not taken care of themselves. They've not had the energy nor the desire to shower sometimes. So sometimes we have to, help them with their ADLs because they just have not had the energy or the motivation to do them on their own. We also want to make sure that we're advocates for our patients and families in letting them know their legal rights, ensuring that they have enough information to make informed decisions, or giving informed consent. And if not, of course, the doctor needs to come in, right? We don't explain things that the doctor should be explaining to give consent, but definitely supporting those, the doctor's discussion on that would be good. And then helping them maybe think of alternatives and supporting them in the alternative therapies or assistance. And of course, an advocate, psychiatric nurse, or any nurse speaking on, the individual's behalf, especially with mental illness, because they can't on their own if they have severe mental illness, and helping them get the mental health services that they may need. The next ethical principle is non-maleficence, and that's required by all healthcare providers to do no harm. And that's part of your oath, your Nightingale's oath that you'll recite at your pinning when you get to graduation. That do no harm. That's always our requirement, is to do no harm, intentionally or unintentionally. Okay, so definitely one of the principles that we follow. And so ethical dilemmas definitely can arise or do arise when there's a conflict between the individual's rights and what is thought is best for that individual. One example is if a psychiatric patient refuses their antipsychotic medication, which in other cases on medical surgical floors, patients have the right, as you guys know, to refuse any medications, right? Well, some of our psychiatric patients kind of lose that right, all right? Because, and we'll talk more about how we weigh, whether we have to force that medication on them. I believe it's on the next page. Yes, it is. It's on the next slide. But it is their right. So the nurse has to decide, okay, how do I maintain the patient's safety with psychotic symptoms? Okay, so they could be hearing voices that are telling them to hurt themselves or others, and it's very important that they get their antipsychotic medicine. So we'll talk more about how you make that decision on the next slide. Justice, of course, is fairness, okay? The right of individuals to be treated equally, right? Regardless of their race, sex, marital status, medical diagnosis, social standing, economic level, or religious belief. Everyone has the right to be treated fairly and equally. And one disparity that we do see in healthcare, unfortunately, is quality of care, which is always a big topic that, in our society, we need to work harder at equitable distribution, equally distributing healthcare. That's been a big problem. So that's one area where we're falling short, and we need to continue to work on that. Veracity refers to one's duty to always be truthful. And some limits to this principle are when the truth could knowingly produce harm or interfere with the recovery process. So that's where there's an ethical dilemma. I want to tell them the truth, but if I tell them the truth, they're going to get very upset and start hitting doors or, whatever the situation could happen, could escalate things. So sometimes we can't always tell the truth. And sometimes that is in psych nursing, that's the case. But we do feel like everyone deserves the right to know their diagnosis, their treatment, and their prognosis. But there are exceptions to that rule. Okay. So the ethical issues in psychiatric mental health nursing, the right to refuse medication. Okay. As we said, we all know everyone has that right, unless, if the client exhibits behavior that is a danger to themselves or others. So the person on the unit is acting out, if they're on the unit, in a way that they can hurt themselves or they're being threatening to others. That's where they lose that right. They will be offered medication to help them calm down. Of course, we're always going to try the least restrictive, and we'll talk more about that at the end of the slide. Let me see when I'm getting, we'll get into that other stuff in a minute. But anyway, if, we may have to force medication on them if they will not willingly take it. Ideally, we'd like them to willingly take it. So we will say, can I give you something to help you calm down? Well, then we may have to get a group together and forcefully give them an IM injection, okay? That doesn't happen often, but sometimes that does have to happen because the person is, going to hurt themselves or someone else. Or they lose the right to refuse medications if the medication has a thought of providing help. Okay, if someone is severely psychotic, has psychotic features, is hearing voices that, are telling them to hurt themselves or others, that it can improve their condition, even if it's not that extreme, then they lose that right to refuse. And then we'll have to determine whether they have to get an IM injection. And usually that is what we have to do if they're totally refusing to take, we can't force them to swallow a pill. So we may have to force a IM medication on those folks. Or if they're just incompetent, mentally incompetent, their mental illness is so severe right now that they're not able to, evaluate that the benefits of the treatment that they're being given. So again, they would be forced medication on them. With any form of consequences, as we talked about, if their behavior warrants consequences, if their behavior warrants medications, typically medications is where we like to go first. If we can get medications to calm them down, then, we don't have to put them in restraints. And of course, restraints is the last resort, and we'll talk more about that. But talking about the right to the least restrictive treatment, all psychiatric patients have this right. They have to trust that we are going to give the least restrictive treatment alternative. Okay. So, and this is subjective in a lot of ways. What we feel like is least restrictive. Okay. But with our training, our guidance from our docs, that's what we've come up with. That's what we try to come up with. So some examples would be involuntary chemical intervention, which is forcing an IM medication on a patient. Ideally, if they'll take it, without being forced on them, that's ideal. But sometimes we have to do that. Seclusion would probably be the second in line. Okay. So taking that person out of the environment that's maybe triggered their uproar, their acting out behavior. So, and sometimes it's just merely taking them to the seclusion room, leaving the door open and just saying, okay, let's talk, you need to calm down, and without, that's probably not the best words to use, but let's talk about this, take some breaths, because you may have to say, you need to calm down before you can come out. Okay. So typically that's what I've seen happen with seclusion is where, the person's taken to the seclusion room and just, okay, giving you some space, let's talk this out and try to resolve the issue that has got you so upset. And then last resort, of course, is mechanical restraints. And we'll talk more about that in just a minute, but that is definitely the last resort that we want to use. Confidentiality is so very important because of the stigma that's related to mental illness. It's very important. Unfortunately, our society has not got on board with not stigmatizing mental illness, but it's hopefully a work in progress, and we're out there to educate everyone so we can improve that situation. But anyway, it's very important because unfortunately there are some places of employment that if they find out that an individual that works for them has a mental illness and has been placed on a psychiatric unit, they may lose their job. So confidentiality is very, very important always, but especially with mental illnesses, okay? And confidentiality, as you know, is where only individuals that are directly working with that patient. So if you're assigned as a student to a particular patient, you have the right to look at their chart. but you don't have the right to look at someone else's chart that you're not directly involved in their care or involved in observing them. Okay. And you can get fired for that kind of stuff, right? So that's our confidentiality, right? HIPAA is, of course, everyone knows, Health Insurance Portability and Accountability Act of 1996. And under this law, individuals do have the right to access their medical records, to have corrections made to their medical records, and decide with whom their medical information will be shared. And we all fill that little paper out every time we go to the doctor. Under HIPAA, there is the protected health information, and that is any health information that can identify a patient, okay? Could be their past, present, or future medical or physical or mental health issues or conditions that can identify an individual. So you're always very careful, right? With anything you take into the clinical setting, you don't put anybody's patient's name on anything, right? Initials, and room number, and they're really funny in psych. They don't really even want us doing that. At least at the VA, they were like, you don't walk out of here with anything that has anything on it. Okay, so we have to shred everything, which I'll find more about once I go and talk to the manager at LifeWorks. I'm sure it's very similar. Any pertinent medical information may be released without consent, of course, in an emergency or a life-threatening situation. There is a box on page 48 that talks about box 3.4 that lists what is considered protected health information identifiers, but we definitely never leave any information out about a patient. We never walk away from a computer turned on with a patient pulled up. You guys know all that stuff. Another aspect is privileged communication. And you've probably seen this in movies where the psychiatrist says, no, I can't tell you anything about what I talked with the patient about. And most states do support that. There is privileged communication unless it can lead to criminal or civil, unless it's related to a criminal act or a civil proceeding. And there's some other exceptions also to that. But, that applies to psychiatrists, attorneys, in some instances, psychologists, clergy, and nurses are all included in that. So we don't talk about what we've talked about with our clients and patients unless there's a situation that there's a danger of not passing on that information. Okay. So with that in mind, that medical records can always be pulled in lawsuits, as we all know. And we've ingrained this into you guys that it's so important. You'll watch what you document, right? Documentation is so very important. It's objective, right? You don't put your personal opinions, what you think, doesn't matter. It's the facts, only the facts, right? So it just needs to include the objective data and statements that support that. So you always want to keep in mind, somebody might look at your notes one day and you want to make sure that they're non-judgmental and that they're objective. Okay. One exception to this privileged communication is called a duty to warn. Okay. And this is a duty to protect. Okay. So a duty to warn is just as the term implies, to warn someone. Okay. So, say if a patient you're talking to and they say to you, I'm going to tell you something, but you can't tell anybody. when I leave here, I'm going to go kill my wife. It's her fault I'm in here, but don't tell anybody. Um, Definitely, we're going to be telling the wife, right? Especially if there's a chance this guy's getting out. But we're definitely going to move it to the instructor, communicate that to the instructor, and then we will definitely communicate it to the nurse, who will communicate it to the doctor, so on and so forth. But, definitely if someone verbalizes a threat and that person can be identified, well, we'll talk about that in just a second. There's 3 criteria, but so there's certain circumstances if a client or patient verbalizes their intent to hurt someone, we have to warn that individual if we know that person. Now, if they say, okay, I'm going to go blow up the Capitol building, there's no real individual that we can really warn about that. Of course, we're going to pass that on, but we can't really tell one person about that. So, but if there is, the person's ID'd, which I guess I'm getting to anyway, the 3 guidelines are, that there's been a threat of violence towards another. If we can know who that person is, ID the intended victim. And if there is the ability to intervene, a feasible, there's a good chance we can intervene and protect this person, intended person. So when those guidelines apply, it's very reasonable for a therapist, a nurse to notify the victim. Of course, you'll go through your facility's policy on how that's done. You probably would not be the person to do the notifying, but you definitely pass it on to the people that need to either get with law enforcement, relatives, whichever, to let them know. And at that point, if someone makes a threat against someone, that is an automatic get to stay with us for a little bit longer. So if they were going to be, I'm getting discharged today, and just between you and I, this is my plan. Definitely that revokes that plan to let them be discharged. So then they would either be asked to voluntarily stay, and if they refuse to do that, then they would be involuntarily committed to prevent that violence, of course. Okay. Most states do recognize that therapists have that ethical and legal obligation to prevent. That's where they lose that privileged communication if they've offered up a threat during a session. And of course, informed consent, we always want to definitely support that. And it is the law, of course, that all individuals have the right to decide whether to accept or reject any treatment. And, you can actually be charged with assault and battery for sustaining, an example, life, CPR, if that client's a no code. That you could actually be charged with that if they've not consented to that. So definitely the rationale for informed consent, of course, is to protect and preserve their autonomy in determining what will and will not happen to their body. One example is with our depressed patients, we can do a treatment called ECT, or electroconvulsive therapy. And we'll talk more about that when we get into the different therapies. But, even though a person's depressed, they can make that decision whether they want to go to that form of treatment. So you do have to have informed consent. Of course, if they're not able to, give informed consent, they may have someone else consent for them. But okay. Any questions about that? All righty. So, of course, some exceptions to informed consent. Oh, we got 1 minute. 2 minutes maybe. I know you guys have had a long day. Trying to decide. Maybe I'll just trudge forward because we've just got 2 slides and we'll get done with this. Is everybody okay, or do you guys need to go? Or are you like done?
Let's just finish these last 2 slides.
Thank you. I was hoping somebody said that. All right, let's do this. Okay, so the exceptions, of course, if someone's mentally incompetent, they lose that right. If the treatment, you're refusing treatment, endangers the life, and we've kind of hit on this already, and health of another. In an emergency, we talked about that. Children, yeah, we talked about that also. And therapeutic privilege, okay? That is where, we always, that right to be honest, or that ethical principle of being honest. This is where this might not happen. If information is withheld sometimes by the doctor because they feel like it may hinder, of course, we hit on this a little bit earlier, or complicate treatment, it could cause severe psychological harm if they find out. One example I can think of families saying, don't let grandma know she's got cancer or she'll stop trying to live. That's a doctor family situation. But I know sometimes that bothers us. She should know. But anyway, family knows best, usually, hopefully, have the best interests of the patient. But anyway, that it could cause severe psychological harm in psychiatric care, be so upsetting as to render a rational decision by the client impossible. So sometimes they use the therapeutic privilege and keep information about the treatment plan from that individual. If the individual has been legally determined to be mentally incompetent, of course, consent can be obtained by a legal guardian. Problem arises if we can't get a hold of the legal guardian, or there's not been a legal guardian designated, but the current mental state of the patient we need to have consent. Then it may be a closest relative, it may be a court. If there's not enough time, sometimes they will have to get hospital administrator to consent, to give permission if time's a factor. But if there's enough time, of course, the court will appoint a guardian eventually for this. Okay, last slide. Restraints, we know, are very controversial. We want to use other measures to decrease the agitation first. Okay, talk down. Find out what's going on. How can we help? Those kinds of things. So that is actually our first line of defense is, just finding out what's going on. What can we do to help? Then, well, would you take your Ativan, your anti-anxiety medication to try to calm down a little bit? And we'll talk more about this. Or we may have to force that on them again. Seclusion we talked about, and then false imprisonment. So Patient Self-Determination Act includes a set of patients' rights, and one of which is the individual's right, of course, to freedom from restraint or seclusion, except in an emergency situation. And that all efforts have been made before that happens. So we all know that federal and state regulations have been made to minimize or eliminate the use of restraints because of the injuries and deaths that we've all heard of. And of course, restraints in psychiatric nursing or in psychiatric care include, the leather straps of the 4 extremities. When the behavior is out of control and it poses an immediate risk to the safety and well-being of the individual and others, And, it's gotten to the point where, we have to resort to that as opposed to medications. But of course, that can be, medication is also a form of restraint. Tranquilizing is a form of restraint because it restricts the person's freedom of movement. Although you'd be surprised the amount of medication these folks get and still walking around like they've got nothing but at least have calmed down. And of course, it's never used as a punishment or convenience for the staff. Talked about seclusion already, actually. And false imprisonment is just deliberately and unauthorized confinement of a person, keeping them from leaving, either verbally saying you can't leave or physically locking them in their room, heaven forbid. And you can be charged with false imprisonment for restraining or secluding a person against their wishes if they're admitted voluntarily. Okay, because believe it or not, we do try to get permission for that if they're voluntarily committed on their own behalf. But we'll talk more about that on Monday. So let me see if I have any other questions. Anybody have any questions for me? Thanks for bearing with me extra 5 minutes. So we'll start with ethical legal issues part 2 on Monday. Does anyone have any questions, concerns? All right. Well, have a good weekend. Welcome back. And you can always email me with any questions you have. And I will see you